Good morning and welcome to everybody that's joining us live. My name is Carolyn Dubé and I'm the Executive Director at Fertility Matters Canada for the National Patient Resource for Canadians who are struggling to build their families. We provide information, resources, education, and advocacy on behalf of the 1 in 6 couples and all of those who are struggling to conceive. I'm thrilled today to be with you during Canadian Infertility Awareness Week. We've been celebrating from April 19th to the 25th the journey people are on, this fertility journey, and providing support, especially in this this time of a pandemic when fertility clinics have shut down and all fertility treatments in this country have stopped. I want to say a very, very special thank you to EMD Sorono. With their generous help, we're able to put this broadcast on. And I'm thrilled to bring these very special fertility experts from different parts of our organization to you today. I'm going to allow them an opportunity to introduce themselves. So thank you for joining us. And Dara, I think we'll start with you.
Oh, goodness. Okay. So thank you so much, Carolyn. This is terrific. And it's such a great opportunity to be able to chat with everybody who's out there. I know people are feeling a lot of very big feelings right now. And so I'm a reproductive counselor, and I'm imagining that I was asked to be part of this panel to help focus on that part of things in terms of how people are managing around their own mental health, managing around relationships with family and friends that they may be living with or that they may be dealing with remotely, intimate relationships, and people who are on their own and really struggling because they're also living alone. And so I'm really here to talk about any of those kinds of things. And so those are the questions that will be coming to me. So thank you so much.
Thank you. Ari?
Thank you, Carolyn, for inviting me, and thank you again to EMD Sorono and the rest of the panel. I think this is a special activity to be together and to be able to discuss things at a high level across this platform. My name is Dr. Ari Baratz, and I'm a reproductive endocrinology and infertility specialist at the Create Fertility Center. So I work in collaboration with all the professionals that are on this webcam. And I think you asked us, Carolyn, like, what are some of the sort of high level comments we want to make? And for me, I just want to remind people that this is not the situation that I or we expect it to be in, but that it doesn't mean it's not going to work out eventually. And I think that's a really important piece, that there is hope. We need to be creative. That's not a plug for my clinic, but we do need to be creative, and we need to look to the left and to the right. So I look to Dara, who's actually on the left of my screen, and to Danielle and to Sarah, and look at all the professionals in our community, in our village of providers, to sort this out and to realize that it eventually will work out.
Great, thank you. Sarah?
Great. Well, thanks so much for having me. My name is Sarah Cohen. My practice is Fertility Law Canada. I'm also very proud to be president of Fertility Matters Canada, and really thrilled to be here with everyone today. So my perspective is a little bit perhaps more unique and a little bit more directed than some of the other people on the panel, just because most of my work is really limited to third-party reproduction. So there are going to be, I hope, some people who are joining us today who are in that basket and have some questions about how to deal with how COVID is interfering with their fertility plans when they're dealing with surrogacy, egg donation, sperm donation, or embryo donation. I'm hoping I can help out and answer questions with respect to that framework.
Great. And Danielle?
Hi there. So I'm Danielle Dubois. I am the clinical director at the Ottawa Fertility Center. I am a fertility nurse by training, been in the field for about 14 years, and having worked in Edmonton and now Ottawa. So I'm open to sort of anything fertility nurse related, but also on the administration side. So working really closely with our physicians in reopening strategies. And I think, you know, that might contain some relevant information that patients across Canada really want to hear what our fertility center is working on. And yeah.
Great, thank you. So thank you everybody for being here. We tried to get a really good cross section of the people who are involved in in fertility care right now, and as fertility clinics begin to reopen their doors, to make sure that we have a cross-section of information to deliver to patients today. So I think we've got a ton of questions that came in as people were registering. So we're going to try to touch on lots of those. So I think the big question, and maybe we direct this to you, Ari, first is, what is the current state of fertility treatment in Canada, and what are where are we in the thought process of potentially restarting or reopening clinics?
Right. Well, that's many questions wrapped into one, Carolyn. But so I definitely will make some comments and then allow the others to provide some color commentary on that. So the current state of COVID, I think that's where it all starts with in Canada and in the world, is there still are cases every day. And even though many of the curves are starting to flatten, we still are seeing cases. And so we still are in this active COVID mode, which from a fertility perspective means that we are essentially still waiting to start cycles. So we are not in the same operational mode as we were pre-COVID. The American, European, and Canadian societies of fertility care have all provided what we call guidances, loosely referred to as guidelines or recommendations, that really no active treatment should be started. Although, so that does mean from a patient perspective, your cycle is not starting today, but you are going to be consulted on. You can certainly have follow-up consultation. Some very basic diagnostics are still available, but anything that's nuanced to fertility in terms of interventions, treatments, diagnostics are primarily on hold, and we might talk about some things you can do away from the clinic. But what's different now than, let's say, 3-4 weeks ago is the conversation about reopening, which is what Danielle was touching on, is much more in the forefront of our discussion. And so as we speak, our leaders, both on the administrative side and on the provider side, excuse me, are actively discussing how we can reopen our clinics in this new COVID reality. The when is a little bit more challenging. I think how and when, how is a discussion that can be had in a very sort of general way. When is really at the restriction of local, regional, and federal jurisdiction. So we're waiting really for, in the case of my province, for the City of Toronto, the province of Ontario, and the Canadian government to provide some broader public opening strategies. But I think that will definitely be regional, depending on where you live in the country. I know this is a national broadcast. It's changing. So I know that PEI New Brunswick are opening up as we speak. In terms of fertility care, I think that's still on hold, and you'll have to go to your specific provider to provide that information. I think that gets the ball rolling. I'm sure there's going to be some follow-up questions from that.
Absolutely. Danielle, do you have anything to add there? Do you feel?
Yeah, I think, you know, it was a very difficult decision for all the centers to close, but the right one. You know, the amount of COVID infections in our reproductive age patients is a large portion of the patients with COVID. So it is a very real concern for bringing patients into our centers at this time, and all of the national organizations and international organizations of fertility experts supported the initiative for fertility centers to pause and wait for government direction. But what they're starting to do now, and ESHRI is the European Society of Fertility, has actually just released as of today reopening guidelines, and they're really good, and they give direction to practitioners on how to do it safely, how to screen, what to screen for, what to put in place before reopening, how to prioritize, and those types of things. And those are what we're really starting to focus on, and that is definitely going to be giving hope to our fertility patients who are trying to patiently wait for us to reopen.
Great. So as you know, I think as fertility clinics, of course, we knew that they were going to close, and we hear in a lot of our support groups online, there's a general sense of panic and maybe some frustration. I'd be interested, Dara, to know, as a reproductive counselor, what are your patients saying about how they're feeling, or how they're dealing maybe with some of these closures?
Yeah, that's a good question, and I suspect for any of us who have been speaking to people, to patients along the way, one of the things that we realize is that this is a group of people who were already under a tremendous amount of stress. So anybody who's going through fertility treatments, who's experiencing reproductive losses and trying to conceive without success, they already have some of those really big feelings around lack of control, uncertainty. A lot of them are feeling really isolated from people around them who don't understand their experience. Some of them are feeling angry and experiencing financial uncertainty because obviously treatment is expensive, and certainly anxiety, depression, those are really common emotions. So all of those things were there before the pandemic. So really the way I'm thinking about it is, if you imagine if you were about to run a marathon and before starting the marathon, you had been well rested and really ready to go, which is a lot of people in the world when the pandemic hit. Fertility patients, as with many people for a variety of different systemic and personal reasons, it's like they've already run a marathon. So for people who are really now in a position where their fertility treatment is stopping, I suspect for a lot of them, that's what it feels like. They've been running a marathon, some of them for years and years and years, and now they're being asked to run another one. So all of those feelings that I think everybody in the world is feeling around lack of control and uncertainty, it's exacerbated, I mean, a millionfold. So certainly feelings of despair, people feeling like there's some kind of universal sign that they're not supposed to have a baby, that they're never going to have a baby. For people who have low ovarian reserves or age is an issue, concerns that this delay actually means they will never have a baby. People being concerned that their funding won't be available for them. There'll be additional delays, which could mean putting them further behind in terms of their own family planning and what they imagined in terms of how old they'd be when they had a baby. For people with secondary infertility, it delays the gap. So the gap between the child they already have and the child they're hoping to have now is even bigger. And of course, for everybody, they're seeing online all these memes and hilarious things about a baby boom in 9 months, and people making jokes about that. And so for people that we speak to, that actually is just like another slap in the face, where that's not going to be, for most of them, their story. And people are making jokes about that. Their friends are complaining to them about how hard it is to be home with children. And even when they're on work calls, where traditionally maybe their workplace was a place that they could escape the social pressures of kids, they're on video calls with people whose kids are coming into the room, and people are holding up babies, and people are seeing, kids' pictures and family pictures behind them on their desks. And so people's personal lives that include children are now being brought into their own personal spaces that have been safe before. So all of those feelings are really exasperating the feelings of anger, frustration, desperation, and deep, deep sadness.
That's a very good consideration, actually. And something that I've been aware of as I've been having meetings and thinking about the patients out there who probably are feeling those exact things. Sarah, I'd love to jump over to you and connect about what are you seeing in your practice in terms of how this is affecting the work that you do.
Sure. I just want to take one step back first and just comment on what Ari was saying before. So Dr. Baratz was mentioning how regional this is going to be, and I, from a legal perspective, really echo that. So for example, I'm in the province of Ontario, where legally, really, we can't be open because we're just not an essential service, but that's not necessarily the same in other provinces. And that may be because, for example, in British Columbia, the clinics chose to close really out of the goodness of their heart, believing that they're making the right decision for public safety. But their requirements to open, or what's necessary for them to open in a different province, isn't necessarily the same as it is here in Ontario. So this is going to be very regional. And I do expect we're going to see things open piecemeal across the country, which makes good sense because the actual virus is not playing out the same way across the country either in terms of the numbers game. What I'm seeing in my practice is probably very similar to what Dara commented on. So my clients are not trying, for the most part, to have children in any other way other than in third-party reproduction, which obviously needs the help of a clinic. And they're completely stuck. Everything is stopped. Most of my clients have been planning, if it's surrogacy, for example, they've been planning for years. And this is an entire process that has been organized. It's not just them. There's other people involved who are helping them build their family. And there are so many pieces to the puzzle that there's a huge sense of loss of control. So for people who haven't gotten started yet, this is very concerning. They're worried that as the surrogate, you know, her life might go on, basically. This could last for a long time. They just don't know how long this is going to go. For people who are already pregnant with respect to third-party reproduction, there's a lot of fear. And I'm sure that's true whether it's third-party reproduction or not third-party reproduction, in the sense that, you know, we just don't know yet to what extent, I'm not a doctor, Dr. Bratz can comment on this, but I think there's questions in the general population, at least with the non-medical community, about to what extent COVID could affect a pregnancy. And then they're turning to us and their other advisors, because faced with questions we've never had been faced before. So, you know, someone's working with a surrogate, they don't want the surrogate going to work anymore. Are they allowed to reimburse her in a situation where, you know, these are questions that we don't necessarily have answers to?
Right. Ari?
So what's interesting about this platform is that as one person speaks, it makes you think about a reaction. It's almost like a little dance that we're having here, and about trying to provide people with a unified message. But that's one of the essential issues here, is that there's a lot of mixed messaging that's filtering down, even in a more fundamental way. Like as Dara was saying, you know, for the longest time, people have been told, hurry up with your fertility, speed up, speed up, speed up. And then finally they hit their stride and there's a big block. So one of the reassuring messages that I think needs to be sent, and no data set has ever shown this, that albeit frustrating, someone's overall prognosis should not be radically adjusted if they have to wait 1, 2, or 3 months. So that's been well documented. That doesn't mean that there isn't psychosocial impact, but from a actual functional sort of biomedical perspective, we believe that there shouldn't be impact. Now that's not to say that after 6 months or 9 months or 12 months, we're going to have an issue. So I think that really has to resonate with people. Certainly reopening strategies have also had many mixed messaging, and I think that's where people have to really find an aligned message, which we're working on. And even to Sarah's point, like, you know, how do we reopen? There's no question that there will have to be some kind of unification, some kind of alignment. But the good news is that the most paramount issue that we're looking at is safety. Safety for our patients, safety for the pregnant female, safety for the unborn child. And even though there are many unknowns, we are gaining a lot of experience very rapidly. And the way the medical community, the way the community at large has aligned, and how information technology has been passed. I mean, you have competitive drug companies working together to solve this. I mean, it's unprecedented collaboration. And so what I learned from that is, number one, is we can get through this together. Number two is safety is not being compromised because we are using existing data. And so just to reassure the viewership, if you are in the pregnant reproductive age, even though yes, there's risk, the risk seems to be quite low right now. I mean, less than 1% of people have severe illness. That's really what we're looking at. Admissions to hospital, ventilation, yes, it's been described in our population, but very uncommon. And most of us, the virus will just pass through us. So that doesn't mean that we don't have to be vigilant, but most of us are going to be operating in a very safe space. And long-term sequelae from COVID is not really well established, but looks very promising.
Great, Dara?
Thank you, Ari. I know I've had a lot of people really very concerned about those things, so those are really great things. I wanted to go back to something actually Sarah said, which is the language that everybody is using, the governments and health providers and everybody's using around essential service. And I know that that's something that that language has been really triggering for people because it makes them feel as though their fertility care is not considered essential. So for anybody who's listening, I just wanted to make sure that it was clear that the idea of essential in this circumstance is talking about life-saving. So it's not, and I really wish actually that that the sort of public health had an ability to use a different language, that it was sort of like life-saving care versus essential care. Because I think a lot of people are feeling like being told that their fertility care is not essential is like, it's not like getting a nose job or a breast augmentation, which are things that people might very much want, but they're not life-saving or soul-saving. And I think for the people that we deal with, this may not be life-saving, but it certainly feels like it's soul-saving. So really being clear, cancer treatments are put on hold, bypass surgeries are being put on hold, all kinds of really what we would consider to be essential services and surgeries and treatments are being put on hold now. So it is not about a judgment or morality call around what is essential to us as human beings, as opposed to will this person die in a short period of time if their treatment is not offered, and if not, then it's being put on hold now. And so I just wanted to touch on that because I know that language is something that people have done a lot of pushback with me for.
Dara, thank you for that clarification. I think that was important to address. Ari?
I think that's one. I mean, I don't ever want to paint COVID as a positive. I mean, it's full of negative, but there have been some silver linings to COVID. And one thing it's done for the fertility community, as it really has pushed that redefinition of essential. I mean, every position statement that's come out from the European Society, American, Canadian, the first line is fertility treatments are essential. They are essential. They're actually in the same category and they have a timeliness to them. The difference is they don't have that urgency like a ruptured appendix or a motor vehicle accident, which are the only type of surgeries that are being, and urgent cancer therapy. And so when you have that dialogue about essential and urgent, fertility care gets put right up against all of the other conventional medical conditions. So for me, that's really I felt very empowered, and that all of these agencies are using that as a handle to re-promote this situation has been very encouraging.
Yeah, that's a really good point. Thank you for addressing that. Sarah, did you have something you wanted to add?
Yeah, I just wanted to add that as advocates, then I think our goal really is that as soon as we open up, as soon as the provinces open up to non-life-saving measures, our goal is to be included right away. So we're not generally, our goal is not to equate us with life-saving measures, but as soon as it's possible to open up, we want to be in there, and we want to be helping our patients get the treatment they need.
Well, just to follow that up, so I wanted to go back to Dara's analogy about the marathon. We know the Olympics have been, obviously canceled. Many of the largest events that we take for granted have been canceled or put on hold, postponed. I think that's what really the message we've been sending patients is that we're going to do everything we can now to prepare you for that next stage. So, for example, the Olympians, this postponement has just put them back. They're back at the gym. They're training. So for our clients and patients, we're trying to identify all those factors that can be optimized pre-treatment. Now is that opportunity, whether it's medical, whether it's optimizing financial situation to be ready, whether it's preparing legals so that we can move forward, or whether it's going back to our mental health. I mean, if someone's anxious or depressed, now is the time, unfortunately, we have to really focus on realigning those moods and emotions and feelings and making sure they're ready to go when we're ready to go.
Great. Dara?
Which actually brings me to a question that I wanted to put out there for Ari and Danielle, actually, which is a lot of the people that I'm speaking to are wondering if there are things they can be doing. So clinics aren't obviously doing, embryo transfers and inseminations and all of that, but can they be doing blood work? Can they be are there things that they can be doing so that when clinics open, they're ready to go? And that would include the intended parent, let's say, as well as people like a surrogate. If people have found their surrogate, is there something she can do as a preliminary medical screen? I'm getting a lot of those questions.
Let Danielle.
Okay. I think there is a lot that they can do, but it's also, you know, to keep conscious that we're all told to stay home for a reason. So, you know, again, doing your screening blood tests in the midst of a pandemic, probably not. Probably best to save those for closer to the time where you'll be able to receive care, because they are relevant to timing it to treatments. But I think Dr. Barrett's really addressed, you know, a lot of home things that you can do, which includes your own personal health, continue taking your vitamins, you know, have a regimented exercise program, focusing on you and not putting yourself through a lot of pressures, decreasing stress. Those are all at home natural strategies. Outside of that, some fertility centers are still offering follow-up appointments through, you know, telephone or video conferencing. So getting those questions addressed that you might have been holding in the back of your mind is still a very possibility for patients of some clinics. And, you know, if they did complete testing prior to the pandemic, getting the answers to those results, putting, you know, some time together to consider their options, treatment options, doing some research on their own from home about what are treatment options if they were to have, you know, certain findings. What are they willing to do if they require third-party reproductive donation, taking the steps, because a lot of those are very long, and finding donor agencies, donor banks, or you know, speaking with someone like Sarah and the legal department, which are all necessary, counselors like Dara. Those are all things you can continue to do because they can be done virtually and safely from your homes. But also it's okay not to put the pressure on yourself. If you know, you just want to take this time to sort of say, okay, we're kind of sold out here for 3 months, but you know, I'm going to be an advocate for myself when the clinics reopen. I have their phone number, I know who to call and what questions to ask, because again, I can't speak specifically like I can to my own patient population. We've been doing Zoom chats with our own patients, but I can say that, you know, a lot of centers still have nursing lines open. They still have their doctor's appointments. And so figuring out what that means for you and what your clinic's going to do upon reopening is going to empower you. And I think that's, you know, really important for yourself, to empower yourself with as much information as you can to decrease the stress, to decrease the unknowns, and to kind of put your own plan in place.
All right.
So obviously this is something that we've been thinking and talking about as providers. You know, what can we do? What can't we do? And so trying to look at this through a positive lens, one way of organizing clients or patients that are at a fertility center is those that are shackled to the center, like the clientele that Sarah described, or maybe Dara or Danielle have, meaning they have a diagnosis or they require the fertility clinic for a very specific high-level assisted reproductive technology that cannot be reproduced at home. But then there's a whole group of patients that fall into that other category. And you may not know if you are that person or not. And so using your provider, using your own basic research techniques, looking back on your consultation, you may fall into that category. And if you're not sure, you can always reach out to the clinic to have a relook at your case and see if you can actually weather out this storm of COVID at home. And so that's what I've been doing all day long is meeting with clients, consultation, and trying to identify those that can actually stay away from the clinic and still be successful. Because we know for many conditions, whether it's infertility, recurrent pregnancy loss, they all have their own natural history. And many people can be successful over time, assuming there are no severe factors as part of their case. And I think the other point is back to our point about local, regional, and federal jurisdiction, is I think if you haven't looked at your fertility clinic's website or webpage or social media platform, you should look at it again, because as of this week, echoing some of what Danielle was saying, as the high-level societies are reissuing statements about opening, the clinics are actively consuming them. And so I know at our clinic, we are doing blood work, limited sperm testing, in a very controlled way. We're obviously trying to minimize and minimize patient encounter. And so each clinic will have a way that they can create this enabling environment so it's safe, but yet still effective, and have your diagnostic test performed. So the high level stuff is not being done, but certainly clinic to clinic, region to region, things have changed. And that's the other important point, is that this situation is constantly being reevaluated. All these directives are being looked at every 2 weeks, if not more frequently, to help give you the most up-to-date answer and direction.
Oh, I just have one thing, Ari, I guess for you. We have had a lot of questions in support groups and that have been coming in through our Facebook Live series this week, especially. Those who may fall into this other group, who know that assisted reproductive technology may or may not be what they need. Is it okay to try to conceive at home? Is it safe right now for couples who may or may not be able to?
Well, so there's two levels of safety, right? So very often fertility patients are very scared to get pregnant on their own because they fear that maybe they're going to be disrupting their process. Certainly if they're in the recurrent pregnancy loss group, they're worried of another miscarriage. So I want to make sure that all my comments are metered against the opinion you've been given by your provider. But for the most part, fertility treatment is an enhancer, so it's not safe to try on your own. The bigger question is in the face of COVID. Safety for the pregnant female, safety for the unborn child. And what we know so far is that there really doesn't seem to be much in the way of vertical transmission. There have been some babies born that have demonstrated COVID, but we think that's probably a very rapid surface transmission, but it hasn't been shown to be found in the blood, in the amniotic fluid. So that's very encouraging. And we haven't really seen a spike in birth defects or more miscarriages in the last 6 to 9 months that we've been dealing with COVID. In fact, many feel that COVID's been around longer than we've even known. Maybe the first cases actually dropped in North America months before we were identifying it. So in some ways, even though that was a missed opportunity, it does provide us with some reassurance. You do need to be aware if you do have any coexisting conditions, so that be it heart conditions, lung conditions, any other significant morbidity like diabetes, you do need to be more vigilant whether you're pregnant or not, because those people are probably at higher risk for COVID sequelae. The only two areas that we're seeing of significance are respiratory illness. So that can happen to anybody pre or post COVID. During COVID, obviously, we think it'll be worse. And there is some suggestion that maybe preterm birth may be slightly elevated. So if you've had a history of preterm birth, I think you should probably hold off. But unless you fall into those specific categories, you might consider, in consultation with your provider, trying. So I can't say that the safety is that much greater currently. The risk is not that much greater currently.
Great, thank you. Sarah, I think you had something.
Oh, I just wanted to mention earlier about a point that Ari had brought up, that although we can't go ahead and do embryo transfers to a surrogate, or we can't do egg retrievals from a donor, etc., people are doing everything they can to be ready for the moment these clinics open. We are ready to go. So I think most of the fertility lawyers, for example, are still drafting contracts even when we don't have our medical screening completed, and whereas usually we would wait until then. And instead, if for some reason things don't go forward, they'll just, it will be on the lawyers will end up doing it for free again if they need to. They're just trying, everyone's really pitching in to try to put people in the very best position they can be, to try to make this as easy as possible in the face of a very difficult situation. I also have to say that I think a lot of people have contacted me saying that they think that they would imagine that during this time it would be impossible to find a surrogate, and that has not been my experience at all. I don't know if it's just that people have more time on their hands because they're working from home or around home a lot more often, or I actually think, or I would like to believe, is that people are just coming together in general. And I'm seeing lots of people finding surrogates right now. So that is a little bit more of that silver lining we've been talking about.
That's awesome. Dara?
Yeah, I wanted to pick up actually on what Ari and Sarah said. So the idea of one of the things that Dr. Barat said that I wanted to pick up on was how scary it is to try naturally when you have had recurrent loss. So that's obviously a really important and insightful thing to highlight. And also the fact that any support that you would get from your physician, from your nurse, from the people at your clinic, you still can get that. So for a lot of the people I see, their issue is not getting pregnant, that they've been able to get pregnant on their own maybe not even needing that fertility assistance. What they need the fertility assistance with is if they are going to do IVF with PGT, and for actually supporting and maintaining the pregnancy in terms of medication and those kinds of supports. And so just to reiterate that idea that if that is a fear that you're having, your doctors, your nurses, like everybody is still present, everybody still cares deeply. And so now is a great time to reach out and to say, okay, if I wanted to try at home, what sort of supports could I get for me to be able to do that? Yeah.
Oh, sorry.
So just to fill that in, so people were asking, what is the clinic open for? So certainly anything to do with early pregnancy support, the clinics are available, whether that's blood testing to diagnose the pregnancy, early ultrasound to diagnose the pregnancy, and any kind of support or intervention. I mean, if the pregnancy is failing, providing medical support or surgical support, we still have the capacity. So again, early pregnancy does still have that status of urgent. So if you're at home in an early pregnancy, don't be scared by the COVID. You can see your fertility doctor, or if you need to go to the hospital's not closed. In fact, the hospital's like the eye of the storm right now because the surges have not happened, and they still are there to help the 99% of other conditions that are available. So on the medical side, absolutely, if you do find yourself that you've achieved a spontaneous conception, or you've decided you want to take that step and try, who knows, maybe there are extra medications that can be used to help you, but unless you engage, most fertility clinics don't have a mechanism to reach out to you at this point. So again, check the website, check the Facebook, the social media platform, and if early diagnosis in pregnancy is paramount. And so we do the blood tests, we do the ultrasounds, and we actually are still having the clinical encounters if required. Just make sure you come to the clinic prepared to be screened with masking, and be prepared for the fact that if you don't pass the screen, if you have a temperature, you might be sent home. That's the only other issue.
Great. Thank you for addressing those. I think that's important, Dara.
And then I would thank you, Ari. That's, I think, so helpful for everybody to hear that and to know that. And then just to piggyback on what Sarah was saying, I'm also seeing a lot of people actually finding their gestational carriers, and this time it's been really heartening. And I imagine there's all kinds of reasons for that. But that's a perfect example. It always takes a while in terms of getting things lined up with a surrogate. So it isn't just about going into a clinic for that medical screening. It is the psychological that the intended parents need to speak to a counselor, the surrogate needs to. If she has a partner, her partner needs to. And the same thing with egg donation and sperm donation. And so those are all things from a legal perspective, and also from my perspective as a reproductive counselor. I'm still doing egg donation and known donor screenings. I'm still doing gestational carrier screenings and all of that counseling. And those are things that are going to be required when the clinics are up and open. So those are all really fantastic things to be getting in touch with whoever is going to be providing those services for you, the legal, the counseling, getting those, as they say, kind of ducks in a row so that everything is ready on your end when the clinic's open.
Great. Okay. So I think it's time for a really big question. How are the clinics going to reopen when we get the okay? Do we know, or what's the talk about? How are we going to do this so that patients are safe, staff are safe, embryos are safe? Let's chat a little bit about that. Danielle, do you have any?
Yeah, I mean, again, it will be very clinic dependent, so I don't want to misspeak for other centers. I can only tell you personal experience about some of our own planning as a center, in the fact that, you know, we're discussing how can we still maintain social distancing. So where most clinics used to have hundreds of patients every morning stream through for monitoring, what does that now look like? Does it mean spreading out our office hours? Absolutely. So I know that's what we're looking at doing. Our waiting room is now quite sparse. Our chairs are 2 meters apart, all wipeable furniture. So sort of our infection prevention and control measures is going up. I think initially, I think a lot of clinics will consider doing sort of a sequential relaunch of services, perhaps starting up consultations before they open up the doors, you know, doing the screening tests, and then, you know, every clinic will be different about what their treatment plans look like. I think prioritizing will be a conversation at a clinic level. I think everybody kind of, that could be an ethical debate for sure. But I think at the end of the day, it's how to safely get our patients through. And those are measures we're already putting into place, as well as I think, you know, it's going to be a high demand. So, you know, talking to our staff, making sure they're still on board and, you know, ready for startup so that we have the manpower to offer the services. I think we also need to really secure personal protective equipment. So yes, we're waiting on the provincial and government, you know, rules to reopen, but we also need to secure PPE, and that's a huge topic that is going around. And even, you know, hospitals and long-term care facilities are really having a difficult time maintaining enough supply and for proper use and changing between patients. And so again, that's another reason that they've called, you know, non-essential or non-urgent services to close, is to filter products like PPE, cleaners, disinfectants, hand sanitizer to you know, critical care areas in the hospitals. And so as we reopen, hopefully manufacturing has really increased at this time and are able to fulfill the demand. So fertility centers will absolutely need to be securing PPE, a consistent flow of that in order to deliver the care that we're going to deliver.
Thank you. Ari?
So there's no question that the two big questions are the how and the when. And I appreciated that you asked how, because the when is a little bit more politically debated. I just want to clarify a few things. Number one of the biggest concerns that patients have, certainly those that have been involved in ART, IVF before, is, are my embryos safe? Is my frozen sperm safe? Are my eggs safe? They're all safe, because all of the clinics have still been mandated to have a skeleton staff to take care and tend to the IVF tanks where everything is stored. So if you are, God forbid, a cancer patient survivor or have frozen embryos, all of that has been maintained according to the standards that were there pre-COVID. So that's
Thank you for addressing that. That's important.
Very, very important piece. Number two is just to provide some color commentary to what Danielle is saying, is the how is actually relatively easy. Like we all agree on how this is going to be done, and there's many high-level documents that outline the application of PPE, social distancing, not the nuance of operations, but certainly the general gist of it. And all the documents that I've seen on the internet kind of look the same. So we all know, we all agree on how this is going to be done. The key issue with when is you don't want to fall into that trap of being a closed clinic, then open, then closed again, because many have shown that that scenario can be very dangerous. Even though we know it may happen, you know, it may happen that through broader spectrum testing, both for virus and antibodies, we may identify affected individuals. And with contact tracing, you could have a situation where something that was closed one day, then open, then close again, may occur. And that's actually, we've seen that across the world. We're seeing certain countries that have opened and that are seeing an uptick of cases. So that's very unsettling for people. And that's why I believe that we do need to have that strategy for how to open, but the when, we should really remember that it's been about a month and a half, just shy of 2 months that we've been this way. And we're seeing so much impact of social distancing and proper social measures. So we're getting ready, and we're getting ready on all fronts. But that exact opening date, I think, is still debated. And I don't believe, from my knowledge, any clinic in Canada has actually given a hard open date. And I encourage people not to pressure clinics to do that, because if we open too quickly, then we may have to close that much more quickly.
Great. We do have some questions that have been submitted. Like I said, we've got lots. Sarah, I do have an interesting one that's just come in through our chat. When will out-of-province surrogates be allowed in clinics? So if we have a surrogate, for example, in Newfoundland and the IPs are in Toronto, when would we be able to get that surrogate from Newfoundland into Toronto or vice versa? It's a great question.
That's a hard one. Yeah, I think that's just logistics, really, in terms of are we allowing travel between the provinces and are there flights? So I can't give you a when because I don't have a crystal ball, although I can hope for you that it's relatively soon. But I can see 3 things that need to happen. 1 is that clinic needs to be open. 2 is there has to be a flight. And 3 is there has to be interprovincial travel. So all those 3 have to be available to you. And in the interim, I'd really hope that you focus and have the opportunity to focus on all the things that Darren and I have been discussing in particular and get all your ducks in a row and try to keep that relationship really strong and keep on doing everything you can to prepare for the day that it is open so you're ready to go.
Great. Dara?
I was just going to add to that the other part of it as well is a recognition that your surrogate may be frightened to travel. And I think that's really important to keep in mind, to be respectful, not to assume that that means that she's backing out or she's changing her mind. It's actually really not common for surrogates to change their mind when they've committed to doing this and when they've committed to a couple. But it is reasonable to think that she might be frightened about getting onto an airplane and being surrounded by people and coming to a big city, especially with gestational carriers who actually live in small towns. And a lot of them don't have a lot of experience on airplanes and in big cities generally. So one of the things that as clinics start to talk about reopening and as the world and our country starts to look at reopening, being open and respectful in terms of talking to your gestational carrier. Does she have concerns about coming to your city? If she does, what are some things that can be done around that? Is there a clinic locally that she can do some monitoring with and get her screening done? Can there be some collaboration between clinics to support that? So really being open to those fears and recognizing that in this day and age of this pandemic, those are realistic things for her to be concerned about. That doesn't necessarily mean anything has to stop, but just being open to the fact and creative, as I think was mentioned earlier by Dr. Barat, sort of creative in terms of how can things move forward in a way that suits everybody's needs and is respectful of all of the bodies who are involved in this care.
All right.
So one of the thesis statements, just to sort of wrap that together, is that this is not the situation that we expected to be in. But I am very confident we will work this out eventually. I mean, that really is the bottom line. So no one could have anticipated COVID, although some argue that there were some markers initially. There are many lateral thinking options, whether it's using local resources, and we've always done that, just we're now going to use them more. Or, the big fear is people are looking at this in a very fatalistic way, like my cycle will never happen. I will never make a baby. The world is ending. And so I can just reassure people, I think everyone around this panel can say that yes, bad things happen, but we've been able to be very creative and work around all these situations. There are many very realistic options being presented, whether they're therapeutics for COVID, vaccine, like all of these things have a plan. And so I would be much more fearful if we didn't have a plan, or if we were dealing with something that was yes, it's novel, but it's not unheard of to deal with a virus and to deal with a pandemic, and we are dealing with it. So we're not perfect, but I feel that the working it out and the eventual timelines are all consumable, and they all seem very realistic to me.
Great. We have been getting a lot of questions about, this is going back to clinics reopening, the triage of patients at the onset of the doors opening and how that's going to look. Something I want to touch on that's not exactly, it's not national, but it does in terms of the Ontario funding program, what's happening with that. So I'd love to know, has there been talk about how do we triage patients, or is that clinic dependent? I'd love to know from maybe Danielle and Ari what your conversations have been.
Yeah, I'll start then. I think nationally, the Canadian Fertility and Andrology Society has not yet launched from their medical directors sort of reopening guidelines, but that is coming. And I would expect that to have some commentary inside of that in regards to suggested practices. I think it will actually end up a bit clinic specific for reopening and prioritization in a very similar manner as clinics have utilized for waitlisting their patients for the funded fertility program in Ontario. Has been quite clinic specific. I know our center does a first come, first serve. So, you know, whoever was in the queue and had their say for reopening their treatment canceled, we kind of go in the order from there. That's sort of been our choice. First come, first serve is a defensible sort of prioritization method. As far as the funded fertility program goes, that is an ever renewing contract. So Ontario clinics have that automatically renewed every year. And so there has been no notification from the ministry that is changing. So I know centers are planning to continue offering their services in the same ways that they were prior to COVID. It just might be a condensed amount of time. So the contracts run from April 1st to March 31st every year, the budget period where we can utilize that budget to offer funded services. And it doesn't run over the year, like past the deadline, unfortunately. So we'll be looking at a shorter amount of time to get those cycles done. But that's definitely at this point still a very possible, realistic, you know, decision that the clinics will make in getting their cycles still completed within the amount of time that we might have left, whether it's, you know, starting up in the summer. If it goes much past the summer, there might be concern that we wouldn't be able to complete all those cycles safely, but I don't think we're at that point yet. So I'd be interested to hear Dr. Barrett's opinion on this as well.
Well, it's fairly aligned with what you're saying because we're both subscribing to the same society. There is no formal triage protocol. There actually has never been a formal triage protocol for fertility care. It's always been self-directed, unlike other areas of medicine where there are more standard ways. Like if you come to the Emerge, there's a very standard way of assessing patients. There is obviously a mandate to help people to shorten the time to conception. That's what we all want to do. So I refer to it as kind of advocating. And I call it, there's positive advocating and negative advocating. So positive advocating is trying to identify those that really need the care more radically, women in over 35, women with lower egg reserve, cancer patients, obviously. And then negative advocating is identifying patients that maybe you don't need to come to the clinic right away. Maybe you can wait 2 or 3 months and let others pass through. That's obviously on a doctor-patient level. It's not a clinic-wide approach. But I do believe that we are dealing with providers that are trying to be human and trying to appropriately use resources. So, you know, to give an example, I'm not going to say that a woman who's 22 years old who's been trying for 2 months is in the same situation clinically as someone who's, let's say, 39 and been trying for 3 years. Obviously, their perception of what's going on may be the same, but clinically, they're two very vastly different people. So, if we don't have a current triage protocol, but we will have to start providing that kind of positive, negative advocating and trying to identify people who traditionally we would just put through the fertility clinic, saying, you know, maybe you should come back in 3 to 6 months and let others come through. I'm just postulating. I do know that we do have guidelines for referral. Like very often a GP will refer a patient in a timely fashion. I mean, half of all the patients we see are in their late 30s, early 40s. So there are many women and men that require therapy early. So a lot of this is new territory. We've never had to triage. I'm very confident with the OFP, the Ontario Fertility Program, Ontario funded program. It is safe. Even with all of the funding that's been provided for so many areas of society, there's been no indication that that program is going to be compromised. So that should reassure people. In terms of their spot in the queue, the queue is the queue. It's still present. I think that what I'm hoping is that clinics will be able to increase their human power in terms of hours and try and make up for lost time. You know, medicine, it's not like other areas of life where you can create more hours in the day and increase production. It's limited by the clinic infrastructure. And but what I do believe will happen is that on all fronts, physicians, nursing, admin, counselors will all open up themselves to try and make up for that lost time. But the other important piece that Danielle touched on is all indicators, all forecasting, all prognosticating is not showing that this is going to last for years and years and years, even though theoretically we say that. We're already making inroads. All of the social distancing you're taking, and I don't mean to sound like the Prime Minister, but I mean, it's true. I mean, like everything that we're doing is working. And that's kudos to every single person, those that are on the front line and those that are staying home. And so from my interpretation of the data, it looks like a late spring, early summer opening in some capacity is reasonable. And once we open, that will really provide us with the confidence to further open. But those are my sort of general comments.
Great. And just, Dara, I'm going to let you go. Just in the interest of time, we've got 5 minutes left. So I just want to, we're going to go with Dara. And then I would like to kind of wrap up. I'd like everybody to kind of gather your last thoughts, and it'll allow us to kind of close the session with.
Sure. And actually, what I'm about to say could end up being my last thoughts.
Okay.
For this panel. You know, Dr. Barat said something I think really important in terms of how triage is going to work and the difference between what people themselves emotionally feel as urgent and shattering emotionally versus medically what actually could be something that is conceived as urgent in terms of your care. And so I think that's a really important distinction. And for people who are feeling really panicky, which is a lot of people, to really ask yourself, and you may have the answer internally, you may need to consult with your doctor, but what are the facts and what are the differences between what is a fact and what is your fear? So a delay of 2 or 3 months, as Dr. Baratz has said, for the majority of people makes a tremendous difference emotionally, but medically it does not. So this delay now because of the pandemic, or a delay in terms of if clinics are triaging, that's a really good perspective to try and take. What is the difference between the fact and what is the difference between your fear? Ultimately, when somebody is waiting to have a baby and they don't have it yet, that is everything and it is devastating. But ultimately, 2 years or 3 years from now, when you look back on this time, if you had a baby right when the clinic reopened, or you had a baby 6 months later, that is not going to make that difference. It matters now desperately because you don't have it yet, but it won't with that hindsight. And so being able to sort of take that deep breath and ask yourself if the panic and anxiety and despair that you're feeling is based on your fears, which are legitimate and understandable and need support, or are they based on actual medical reasons why there truly might be a reason you may not be able to conceive because of a delay? And that's a great thing to be able to have that conversation with your medical staff.
Right. Thank you, Dara. Sarah, do you have any closing words?
No, I mean, I don't have anything really all that new to say, just generally to lend my support and tell that I do have to say I've been incredibly impressed with the grace and the generosity shown by a lot of people during this COVID crisis, including the clients that I'm working with. I'm certainly super impressed with how people are, and as Dara said, they've already run a marathon and they're still going. And people are doing a fabulous job and keeping their morale up high. And you know, I very much hope that this conversation just helps to keep that morale up high and know that there are things you can be doing to put yourself in the best position as soon as we're open, and we're all looking forward to being open again as soon as possible.
Great. Danielle?
I think Dara and Sarah said some great words already. So really, I guess I'll just say 2 things. Trust in your clinic. So your centers are really there for you, and we are strategizing, you know, at a management and a physician level, daily, weekly, all to put safety measures in place for you and to reopen and, you know, considering lots of different things, all with patient-centeredness in mind. And second is to look after yourself in a way of, you know, all of the encompassing things we've talked about, mental health, physical health, but also have a voice. So as much as you need to trust in your centers, that doesn't mean just sitting by. It means speaking up. It means, you know, asking the questions. And I think that's really important. been in this process, because we do want to hear from you, and maybe you have great insight as well and can help us, and it's really a partnership. So yeah.
Great, thank you, Danielle. Ari?
I just want to come back to the positive thinking piece, which is that certainly as Canadians, this is not a situation we ever expected to be in, but we have to have confidence that we will work this out eventually. And it is not unreasonable to think that way. It's not cherry coating this. We have the capacity, we have the infrastructure, we have the will, the desire, we have the providers, we have all the ingredients to come out this in one piece. It's going to be eventual. That's the piece there. It's going to happen over time.
Great, thank you. Well, we are at 12 p.m. Eastern on the dot. I want to thank all of you, all of our panelists, for being here today, for sharing your expertise and your insight and your information with us, the patient organization and the patients that we support, and everybody else that's been on this podcast. Thank you for your time today. It is Canadian Infertility Awareness Week, and we are celebrating family building in all of its forms this week through Fertility Matters Canada on our Facebook page and all of our social media platforms. I do want to give a big shout out and thank you to the generous help of EMD Sorono for allowing us to be able to put on this webcast for you today. If you weren't able to join live, you will be able to watch the replay. We'll have it posted on all of our social media channels, and I believe there's an email that's going out with a link to this session. So thank you. Please check us out on social media or on our website, fertilitymatters.ca, for all of the information that you need to help you on your family building journey. Thanks all for a great session.
Thanks, Carolyn. Thanks, everyone.
Thank you.
Bye.
Bye-bye.